Now, as a health system leader, I want to inspire the clinical teams to get the tools they need to improve care. The data mapping is a blip in all the things they need. And by the way, they don't need to see that. That is what the data leaders are for, and the informaticists and the architecture teams and all the disciplines that I don't even need to know. What we do is with the front door, we have a path of saying to any clinical group at Intermountain, hey, you want to standardize this best practice? Tell us what it is. Go through these 5 steps. If you go through these 5 steps, you're going to get to full implementation. You're going to scale it in every location you want. You're going to be able to sustain it. And then you'll have all the tools you need to run your quote unquote business, which is really just better patient outcome around this best practice. And we have done that in a repeatable, scalable way, Jono.
Hello and welcome to Clinical Changemakers. Today on the show we have Dr. Raj Srivastava. He is a pediatrician, has an MPH from Harvard, is a professor of pediatrics, and the Chief Clinical Programs Officer at Intermountain Health. Dr. Raj Srivastava, welcome to the podcast.
Thanks, Jono. I really appreciate being able to be here.
I'm really excited to jump into your experience in the care delivery science space, as well as integrating clinical best practices at scale at Intermountain Health, and your thinking around learning organizations. But before we do, I wanted to touch on a key question that kind of underpins a lot of this work, which is, why is it so hard for us to get best practice evidence and then apply it in our clinical work?
I think there's a few things about why it's so hard to get evidence-based best practices in that daily practice. First of all, I think it's how we start off in medicine. We've trained, we've learned, it's taught to us. We have to understand where evidence comes from. And that's a really intense period. And we're taught by some of the world's experts in every medical school around the world, and some of them have generated it, and we're watching them apply it. So we get inspired, and we're excited to be that type of clinician, practitioner to help our patients. Then we go through additional training after medical school. There's residencies, for some of us fellowships, and then we're done. We've arrived. Yeah, ta-da, we're attending physicians. And turns out being an attending physician is also a journey, where you're starting off as a junior attending physician and then sort of mid-career and later. And I'm probably on that mid-career, slightly over that phase. Here's what I would say as I've watched. I have so many thoughts about evidence-based best practices in my own practice because I've trained, I've learned, I'm ready. I'm somebody who generates some of that evidence, or I have colleagues around the world that are working on things that I know it's about to come out, or I see it come out, and I just want to apply it. And then you go to work in a health system, in a hospital, in a children's hospital, for my example. Turns out that is not how the day is set up. How we're set up, the time we round, how the nursing flows are, how the doctor's flows are, how we interact with the electronic medical record. There's a lot of things that I'd say make it hard to practice the way we want our providers to. And just the rounding time, somebody gets sick, we got to run to that patient. And by the way, everybody wants us to do that. But then we've fallen behind over here. We're so busy. We don't know if we have enough staff. This sort of sets up a world of reality versus aspiration. So I think getting evidence-based medicine into the hands of providers so they can use it exactly as they need it is completely aspirational, and we're going to get there. I have some ideas, and I know others do as well. And listening to what the front line truly needs to do their jobs better, let's not forget that. Let's not do something to them. I found this to be very powerful in change resistance at the system level. Let's co-create with them. When the front line feels we're actually offering, what do you need? What are the resources we can help? We'll co-create. Of course, they don't have the control of the resources or some decisions, but that's what executives can do. And that's their role, is to make that easier. And so I just think we don't do change well at health systems. So people are kind of beaten down.
What I'm hearing with the application is that the scientific method have narrowed down the range of possibilities from infinite possible approaches to healing down to some sort of narrower area, but that area is still extraordinarily large, extraordinarily complex, and is always changing. And as we go through our training, we absorb aspects of this and elements of this, but we aren't robots. We're not downloading this and storing it in our memory forever, and it's just available for us to retrieve on demand. And then, as you say, the work environment, some of the stuff that is so important for junior doctors around writing a discharge summary so that the patient has the information to go home with, as you mentioned, an emergency call or a surgery that has to happen. All of these constraints really make those opportunities for application and retrieval of that information really, really difficult. And then the final piece there is around the patient's needs. The application of best practices is core to how we should be delivering care, but we have to make sure that that patient is being heard and their needs are being met as well. And so it sets up just this really complex space. You've been making some inroads into that space. What are the inroads that you've been able to make, and what have you learned along the way?
One of the pieces that I've learned in my research hat was moving from describing type of research, which has been great, to application based research. And what I mean by that, a lot of people, there's a whole movement around quality improvement, which I have grown up under. There's also a movement of implementation science, which I could call myself one, although I'm not sure I qualify as a card carrying one. I didn't do my PhD in it. I came up separately as a physician doing some research training, but I happen to, work with teams and we have large grants and we're recognized for some of this work. And so I work with people who are true card carrying ones, just like true quality improvement experts. Here's what I've learned. When you're applying the best research to helping care get better for patients, you can create something and think it works on paper. Say maybe you put the grant together or you submit it. The actual planning becomes, okay, what is the problem you're trying to fix? What is the workflow of all the front line that are going to have to understand, quote unquote, get on board? And actually, the secret is inspire that group to come on board on the problem. Is this a big enough problem? Should we solve it together? That's just step one. When was the last time people sat down and said, I know you have all these problems. Okay, well, some of these are small problems, right? Oh, yeah, okay, well, so and so has broken the fridge, so we got to call, environmental services so you can get some, cold drinks when you're on service and things like that. Okay, that makes sense. What about the big ones? We have this problem with our patients and it's affecting so many. And how are we going to do that? I'll just give an example, Jono. I learned something. There was this issue called patient handoff. So, the end of every shift, there is an opportunity for the doctor to hand off to the next doctor. Hey, what just happened and what needs to happen next? I got involved in that around 2008. By the way, there wasn't a ton of science around it. There are about 50, 60 individual studies that gave us clues. But I got involved with a group that said, we're going to help resolve that problem. And we're going to measure the impact it has that's most important to the patients. And what that was harm, because we have harm we're giving to patients in hospitals. So if we're doing it, and by the way, the system is perpetuating it with poorly done handoffs, we didn't train doctors how to do it. Even if we train it, not everybody's doing it. And then, of course, crises come up. And so sometimes you can't do it. And every specialty does it differently. We got involved in a solution that was co-created with a bunch of different disciplines. And then we applied that solution in multiple settings and learned iteratively what was working and what wasn't working. So even though it was a study and it was funded, we ran it like a large quality improvement project and said, wait, what do you need to get better? And by the way, can you tell the other sites that's what they need? So there was this amazing rapid learning wrapped up in the rigor of research. That to me is the essence of what we can do in medicine is work with the front line, give a little bit of rigor, but really have that frontline voice be engaged to help solve the solutions. And I have seen the most amazing examples that have helped not one patient, not even hundreds, but tens of thousands of patients as those programs are getting rolled out.
Now, I want to go one step back from the story that you've told, which is how do you get the space? How have you had the leadership above or adjacent to you to allow you to go into these sorts of spaces, to explore, to get those ideas? Because there has to be, I guess, a vision and a system wide approach that says we are going to go down to the ER and listen, because it can be quite intimidating, right? The health systems are under lots of strain. You worry perhaps that going down and listening to the clinicians, all you're going to hear is money and staffing. Those things still may be true, but there may be other ways to address some of the problems. So how have you had that space to go and do that good work?
That's a great question. So, in the example I gave, it was done in a pure research world. The beauty, if you're a researcher, is you ask somebody to pay a few $1,000,000 and a federal government or agency pays you for it. And then you get to co create because you're buying people's time. Now, the challenge with that is most health system leaders look at that research and they're like, well, that helps you. Are you also helping us? And what I realized was there's actually a potential disconnect between administrators and researchers and clinicians. And so, what I've learned, and about a decade ago, I switched roles where I became a leader at my health system, Intermountain Health. That's what we call ourselves now. We changed the name a few years ago. And what I learned there was health system leaders are hit with lots of things in any given day that sound good. Hey, I want money for this. I need this. However, what I also noticed is everybody recognizes success in the same way, but they don't know how to get it started. So if you're a researcher, you're like, "Oh, I need an external grant." If you're a clinician, you're saying, "I wish somebody would listen because I can fix this." If you're an administrator, you're saying, "I got hit with 100 requests today. What's the one or two that if I turn on, because I can't turn them all on, are actually going to help the patients?" Every at the center of that, say, triangle is the patient and the outcomes we all want. What I have learned at Intermountain as a learning health system, at the very core of what that means is that means they're using a scientific method, just like I used in medical school to learn, just like I use in my patient care, is the board, CEO, senior leadership going to adopt a learning health system model, and there's definitions out there. My definition is you're having a scientific method. So you're not looking at one project, you're looking at the totality of projects running through a scientific method so you can learn, by the way, how did we do on the outcomes that matter? Financial, clinical, operational, or experience. Two, what were the systematic barriers in our health system that are on us? What are the systematic facilitators that we have done that really get the right stuff turned on? And then what's the one off barrier and the one off facilitator? And what I mean by that is sometimes I think there's a problem with, say, data. Well, is that like data for every single project out there and there's a challenge and we don't have good systems or we're struggling with our leaders or something like that? Or is it that that one hospital is not achieving results because it's a one-off barrier and it's not the data, it's something else? So what I have learned is how do you bring that mentality? And I'm lucky because Intermountain Health is a learning health system. I've just been able to see how we can accelerate that for all the hospitals and clinics that we have.
When you say Intermountain Health is a learning health system, I presume it probably hasn't been one forever. Do you know much about that journey and what maybe stage of the maturing into that are you guys kind of sitting in at the moment?
So Intermountain Health next year will be 50 years old. I'd say the first 20 were just getting set up. I'd say the third decade was learning to be a learning health system. And Intermountain was about a fifth the revenue size it is now. But that was kind of the model a lot of people know about and have learned about. My mentors was there. There were some key leaders. They did unbelievable things. My mentor was the chief quality officer, Brent James. I moved from the East Coast. I was at Toronto and Boston thinking, I'm just going to work at these large children's hospitals, and met Brent and ended up trying the 1 year experiment living in Salt Lake City with my family, Jono. And by the way, I'm year 23. And so I've just seen this amazing journey. And then what I would say is Intermountain got much bigger and a lot of leaders came and went. And what I see now is our current leadership in the last couple of years, they are embracing that model of being a learning health system and doing it over the larger footprint. So to answer your specific question, what stage of maturity? First 20 years set up, next 15 years riding the wave. And I'd say Intermountain rode the wave early, right? Data systems, quality, spreading best practices, getting docs on board, taking out unnecessary variation. Turns out all those things, Jono, every health system now has, which is amazing. That means, yeah, you're an early adopter, but that doesn't mean you're always an early adopter. Let's let all boats rise together. That's what's amazing. Now the challenges in healthcare, at least American healthcare, we're in the world of merger and acquisitions. And so Intermountain, 5 times bigger than when I joined or so, largest rural area, I think, in a health system, number 10 size in nonprofit healthcare in the US. And yet, what's the vision? Do we have a scientific method? And then are we getting governance around it? Are we implementing? Are we tracking the data and learning the systematic barriers and facilitators versus the one-off barriers and facilitators? So Intermountain's gone from 1 state to 6 states. So I'd say in a way, yeah, it's cool. Intermountain has stuff to rest on. Turns out everything is new. So we have to learn it differently with groups that are now under the larger Intermountain umbrella. So in many ways, you could either say, oh, you're so mature, you've got it down. I'm like, yeah, I'm meeting people for the first time that are saying, wait a minute, what are you talking about? So I don't know how to answer what stage of maturity that's in. We might just be learning again.
Perhaps it's about how the evolution of these types of organizations, you never just perfectly find a way and now you're on easy street. You find new complexity, the world changes, politics, payment, all these sorts of things change, people change. And so there is a degree of maintenance and growth that is always needed. I wanted to pick up on 2 specific bits that you spoke about there around systematic facilitators and barriers. In your experience, what have been perhaps some examples or some principles that you often thinking about when you think about those 2 concepts?
There are many barriers and facilitators that are well known out there. Leadership, is there a strong vision? Do you have an electronic health record? Do you have the data you need? Do you have front engagement? And many, many, many more. It takes all of that in sync to do something at scale and sustain it that has better patient outcomes. Now, everything I just said, that's the vision. That's why I've stayed at Intermountain. And that's why I'm like super privileged to be a leader there. That to me is the true north. Even if all the changes you mentioned before, that stays constant. Okay. If that's the constant, then now we're larger. We had 9 electronic health records when we merged. We're about to switch to 1. Okay. The 1, everybody's like, woo, that's going to solve everything. And it's almost like it's going to drive your car. I'm not so sure that's true, but people are acting like that's true. Here's what I hypothesize. Is a single EMR with all the data the solution to the systematic barrier everybody's facing? Oh, our data's not aligned, and cost data, it's not even, is it charge data or is it cost data? And, do we have all the right clinical outcomes? Do we have the patient experience outcomes? Do we have the caregiver outcomes? Are they all in this magical database that anybody can kind of reach in and pull out and then know what to do? My concern is, in the world of big data, Joe, people think that there's that solution out there. And I'm going to say it takes discipline to create that repository, organize it so that as clinicians need what they need to improve the frontline care, they can reach into that repository and pull out what they need and not a lot of noise. I'm a little worried philosophically. We're not actually having the conversations on systematic barriers and facilitators. We're stuck in the world of AI can solve everything. Big data is this. We have no funding. The politics in every country seems rife. We're talking about working apart than together. I kind of come back to first principles. I went to medical school because I want to be a doctor because I thought I really want to help people. I still feel that way. Now I want health systems to have that same attitude of we're in the business to help people. That means the decisions we make, we are thinking about what the data as a systematic barrier, and we are setting it up. And then everything we run through that pipeline around data, we're assessing on the back end. Are we getting what we need? When a vendor comes and says, oh, we can solve this, wait a minute, is that what the vendor wants? Or is that what our patients need because the frontline staff are noticing that or the patients are noticing that? And our decisions are made in that mindset. So then when we do all the integration work to get that functioning, it's worth it. And by the way, we're still tracking the outcomes that matter. Patient outcomes get better, caregiver experience is better. That's sort of the piece that we need.
I agree with you. There is a real challenge in how some of these new technologies, I think, make us ask more critical questions about what we're trying to do and how we've done things in the past, but don't necessarily provide us with those answers. And I think your first principles thinking is on the money there. I wanted to ask, how do you understand this space when clinical care and clinical best practices brush up against forces that sit outside the health system, perhaps policy or politics or socioeconomic status, all of those sorts of things where, as clinicians, we want to help kind of anyone. How do you kind of wrestle with those sorts of challenges?
When I have a leader with me and they say, Raj, there's this best practice, and I can do it for all patients with this particular condition. And because it's Intermountain, we can reach all these things. There's a lot of challenges that leaders facing, including things outside the health system, right? Costs are going up for supplies, which we're wrestling with. How we fund healthcare in this country is always a challenge, in the US in particular. Are we having an equitable approach to the patients we want to help? So are we leaving somebody behind simply because they look a little bit differently and we haven't taken the time to understand or really capture them? In my mind, I feel that when we have a method to spread a best practice, can we then, on that method, base some of those challenges that you pointed out and then improve? Let me give you an example. I think health equity is a big issue in this country for sure, likely many countries or every country. If we have a method to spread a best practice, if you look at the data, turns out you might help the whole population. This is a concept that's been around for a long time, maybe about 15 years, maybe 10 years, because there's a paper that points this out. Oh, yeah, the adherence to the best practice gets better, the outcome gets better. Then the group looked at subpopulations, race, ethnicity, do they live in a city or do they live in a rural setting? And it turns out there are subpopulations that may have gotten worse, even though the entire group got better. Okay, it is 2024. What I'm really excited about healthcare is actually healthcare is talking about the conversation of health equity is our problem. It's not just a societal issue, although it is. It's not just a government solution that we need, although we do need help. It's not just a private sector thing, although it is. It's not just that something every day people come to work and feel, was I authentic at work? Was I respected? And did people treat me the way I'd want? And we just want that everywhere. Some people's outcomes may be worse. And now we know it because we're tracking it that way. What we're trying to do, and I think others are as well, bring in that subpopulation and say, hey, we may have got this wrong. We ran this big best practice. Things aren't better. Help us. What did we get wrong? Redesign this. Ideally, we do it at the beginning, Jono, but I may be giving us too much credit all the time. So it's fine. We've had the data. Let's find it, but let's talk to those populations. And I've seen leaders do that. That is what's really exciting is, oh my gosh, they feel the weight of the world with all these socio-political, financial, other things happening. Now they're focusing on what is in their control and what can they do to make their part a little bit better. So watching a group talk to one of these subgroups and in the analysis, reaching out to that population, getting them to help them redesign the process, even change the outcome metric a little bit because it wasn't as meaningful to that population, and then start to run that project and seeing those outcomes get better, to me gives a little bit of hope that we can only control what we can, but why not choose to make sure we're being equitable around our patient outcomes in every condition, in every setting?
Yeah, I guess what I'm hearing is the idea of that co-creation, and that I guess historically medicine has the information and the approach has been so tied up in clinicians' thinking and approaches to problems. And what you're saying is some of those answers are actually out there with our patients, with their families, who can actually tell us what they need. I mean, it sounds really trite and really, really obvious, but actually requires space, leadership, and systems that can support that type of curiosity to then go back and build out either those new structures or those new research questions to help validate the assumptions or push them away. Now, you've mentioned data a number of times in this conversation, and I know early in your career you got an experience leading some work in the space of big data. What did you learn about that experience?
I got involved in big data before we called it big data, and definitely had an interesting experience. Maybe about 15 or so years ago, I became chair of this national research network, pediatric research in inpatient settings. And we were a group of 6 large children's hospitals, maybe 6 to 8. We were the executive council of about 100 hospitals. And our charge was, hey, how can we get data in the hands of hospitalists, which we are, pediatric hospitalists, around the conditions that they're facing in order to improve care? And so there was a data set that existed, and it was essentially billing data, which is great. But billing data is, kind of can give you good summative data, but it's not the same as having patient care data where you want to make a change, which essentially means all the results in the EMRs. There was a colleague of mine, Dr. Ron Karen, who's the current CMO of the Children's Hospital of Philadelphia. And Ron and I and a number of key people, we wrote this grant, and we got $9 million from the federal government to basically take results from 6 large children's hospitals and map it to that billing data set. It's called PHIS, Pediatric Health Information Systems. And this is 2000, early 2010s is when we got this grant. And basically, we spent a few years taking every single lab result, all the microbiology reports, and radiology reports, not the actual MRI scans. That was too hard, but just the reports, and merging it with this data set of 6 large children's hospitals. So, maybe 150 million labs that had to be mapped. Here was the test: map it, make it meaningful, and then have clinicians come and pull the data of their cohort. The thing about pediatrics is, I should say this: kids are generally healthy, thank goodness, and don't need a hospital. Sometimes kids need a super subspecialized help, which is only in a children's hospital. And there are kids who have accidents, kids who get serious illnesses, kids might get cancer, all these things that require help in children's hospitals. And each country has children's hospitals, and you only need certain amount because the local hospital can do a lot as well. In a children's hospital, you get super rare conditions. And if you take 6 children's hospitals and add them up, now you might get to a meaningful number that clinicians can make good decisions around, as opposed to their one in the clinic. Oh, maybe I have 200 across 6 children's hospitals. What can we learn? So that's what we tried to create. Okay, here's what I learned. Oh my goodness, that was a lot of work. By the way, I kept telling people if we were not being paid $1.5 million a year, I'm not sure I will want to be on this project. So much work, so painful. Okay, number 2, we got to deal with the chief health information officers of the 6 large children's hospitals. Super bright people, and everybody has ideas how to do this, and we all needed to create the vision and the plan together. It is really hard when you're taking different disciplines and arriving on a plan that's going to run in 6 children's hospitals. That was a leadership test that I did not know walking in, but learned a lot doing it together. 3, just because you build it, they won't come. Talk about a bummer. We built the database. Our vision was there would be thousands of papers coming out of this, learning this and this and this. I flew to all these national meetings. I remember being at the World Genetics meeting, by the way, and explaining to a bunch of geneticists and showing them their labs and being like, hey, I don't even understand these labs, but we're gonna like get it. And you guys, this rare condition, you just take it, run with it, look at it. And you know what I got? A lot of people look at me like, you're crazy. Who are you? You're not even one of us. I don't even know why you created this. Like, it turns out, Jono, some ideas are earlier in the phase, and you've actually got to bring people along in the co-creation. We didn't have the bandwidth. We were co-creating with the informaticists and with the hospital leadership and with the clinicians. And what we left out were, okay, well, there's like a bunch of subspecialists. We would have had to bring them along to co-create it too. And so, believe it or not, I still get calls around this database. It's gone into a different phase of, hey, this is an amazing idea. I really want to do da 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 da. And I'm like thinking, oh my gosh, where were you like 15 years ago? And the tools that we used for artificial intelligence and things like that were a little bit different. Although not much different. Yeah, the computing power is amazing, but these large language models and things people are talking about are things that we kind of played around with to kind of make this work. I'm really humbled by that project. I feel it kicked my butt. I thought we were doing something that was going to solve everything, and it turns out I'm going to own this. Maybe I was not the best communicator, and it was hard vision to execute. Now I see those same conversations everywhere. And all I'm sitting there is thinking, oh, we're not going to do all the mapping. It's not worth it.
There's so many bits that I wanted to pick up on, and you said it in the last bit there, just how complex it is to map huge data sets like you've done, which is incredible. And it's a really fascinating piece, which I think often gets kind of lost when great ideas come along, which is it's almost like the marketing side of things. How do you market? How do you onboard? How do you facilitate others to pick these things up and to do some of the work? When you reflect on that, what could have been done different, or what are you doing now that enables people to be brought in so that they can then take these great ideas and run with them?
What we're doing now is vastly different than how we approached it before. Before, it was a research project where we are going to build it and the researchers were going to come and there were going to be a lot of papers. Now, as a health system leader, I want to inspire the clinical teams to get the tools they need to improve care. The data mapping is a blip in all the things they need. And by the way, they don't need to see that. That is what the data leaders are for, and the informaticists and the architecture teams and all the disciplines that I don't even need to know. What we do is with the front door, we have a path of saying to any clinical group at Intermountain, hey, you want to standardize this best practice? Tell us what it is. Go through these 5 steps. If you go through these 5 steps, you're going to get to full implementation. You're going to scale it in every location you want. You're going to be able to sustain it. And then you'll have all the tools you need to run your quote unquote business, which is really just better patient outcome around this best practice. And we have done that in a repeatable, scalable way, Jono. So the data mapping is just one of those steps that they don't need to look under the hood. What I am doing is working with my leaders who actually are leading those clinical teams. And here's what they place: there's trust in the health system that we're designing it. So when they get what they need, it's going to work. And honestly, we're kind of halfway through the TBD. We just merged. We are creating enterprise data level dashboards that, for example, if a patient has a stroke in any one of the 33 ERs, that data is available in real time to help the frontline get that patient gets the care they need with that clot busting drug if they need it. And if they don't get it because they shouldn't get it. And we're tracking the outcomes. We are testing that in over 20 simultaneous enterprise projects across all the disciplines, inpatient and outpatient. So the mapping is just map as needed. Do not map everything.
Also, we'd spoken before about just how the geographic space that Intermountain covers, it's something like 630,000 square miles. And I did some quick sort of Googling, and that's France, Germany, Spain, and the UK, roughly. That dispersal of care that needs to be coordinated is quite incredible. And I can imagine there are some unique challenges in that space. How do you approach the governance at that enterprise level such that you get that alignment, you get the outputs, you get the reporting, but you don't get too stuck in, because you need people to fix problems that are perhaps more local and parochial, but also still maintain that more global approach?
So, Jono, one thing I've really appreciated in the last few years at Intermountain is we have set up, this is a term my boss, Dr. JP Vallum, the chief clinical officer, says, which I love. We've set up a clinical ecosystem around that. And I am a health system leader over a couple of key entities, and by design, not all the key entities. And there are governance structures that require vision, oversight, prioritization, and then implementation plans designed, and then running it to ground in those key clinical areas, and then collecting the data and learning and feeding back to the overarching system. I have never seen that anywhere in any health system. Here's what I've seen. I can take this one stroke, for example, and man, we're doing really, really well in stroke. And we're knocking it out of the park. And it took us years to get there. And we haven't dropped the ball. And we're sustaining now. By the way, healthcare sustaining, right? Sucks. We're only 5 years into, I can tell you with confidence, we're sustaining on 6 projects at scale that are meant to be at that scale. Okay. Because I have live dashboards. We only fell down on one of them. And then guess what we did as a learning health system? My boss wasn't angry that we didn't meet the mark. Here's what he said: learning health system, how are we going to learn how to make it better? And so the researchers went and got a grant, and now we're studying what went wrong and how we're going to improve. Talk about super cool. Okay. So doing this at scale is incredibly challenging. And that's kind of what I feel I spend my full-time amount on, is organizing that oversight, running it to ground, and coordinating with my peers, taking out the barriers. Here's the key of that success. We have one project in the state of the merger that's actually gone into the new area. And that frontline ICU team, they're standardizing care in ICU care. So I think I gave an example. Stroke care you can do, but I don't see it in a dozen areas, or I don't see it in 20 areas. doesn't every clinical area deserve at least one project that's evidence-based medicine is at scale and being sustained? By the way, I think the patients would say every freaking area needs to have that happen because the patients would be mortified that we don't have that. So if patients are hearing this, you're going to get some feedback on this podcast. I don't think we share that with patients because it'd be really demoralizing. Here's the thing though, we can co-create a model to do this. And that's what I've been super excited to see and try. Can I tell you it's working? Invite me back in a few years and then I'll give you an update of how we've done.
So much of what you've spoken about is, in my observation, also about how you create really good interpersonal relationships so that you can have trust that information is being shared amongst your team and your leaders and things like that. What are some of the interpersonal skills or approaches that you apply in these really challenging and complex spaces?
As a healthcare executive, I hate gotcha in a meeting. That's not what that should be about. And I've watched it too many times. So read the pre-read, do all the homework. And by the way, if you don't hear, I text, call, let my colleagues know this is what's happening. Hey, this thing is going to come down. I'm just giving you the heads up. You may not agree. Your team may not agree. Let's talk it out. And the thing is, when you're in setup phase, you need to do that a lot. Everybody always talks about the meeting after the meeting. I'm talking about the meeting before the meeting of not I'm gaming the system so everybody has to parrot what Raj said. No, no, no. By the way, people don't do that anyways. Even though I might have some change management skills, no, you can't get somebody to do something they don't want to do. And that's not the purpose of having all the executives agree. We all just want to see the same outcome. We just want to use the tools we've got and the assets we have and the responsibilities and the resources to all come together, not magically, by design, and then learn, is it working the way we want? So, Jono, I think a lot of things I've learned is have strong interpersonal skill, use those skills to make meaningful connections, get to know your leaders, get to know, let them know you, and then share, hey, if I misstep, just call me before. That is not my intent. If I didn't show up that way, and by the way, I apologize for how I show up if I don't feel I show up well. And others do as well. But here's the thing, we're now a year into this role that I'm in. Oh my gosh, when there is trust, wow, watching things turn on, it's faster. It gets to the patient more because all the resources are falling into place. The teams are engaged. By the way, a lot of the frontline teams, they don't know what's happening in the executive room. They just assume we're humming day in and day out or that we're never humming. I'm a little worried they think we're never humming. Jonah, I think I'm in this role to make it always humming.
I think that's a great note to end on. I really, really appreciate all of your insights and the fascinating work that you're doing at Intermountain Health. So thank you so much for your time today.
Jono, thank you so much. Really excited to be here. And do consider inviting me back in a few years so I can give you the update of how's it working now.
Perfect. I'll see you then. Thanks, Raj. And that brings us to the end of the podcast. If you want to go deeper about any of these topics or join in on the discussion, visit our website, clinicalchangemakers.com, or our YouTube channel. Finally, if you enjoyed our work, please give us a rating and share your favorite episode with a friend or colleague. Until next time, take care.